Welcome to Focus on Seniors, a television show sponsored by Helping Seniors of Brevard County, Florida. The show is designed to make you aware of senior issues, needs, and resources available to help us age in place and with dignity. This show will help you as you develop your own aging and care plan.
I'm Joe Steckler. Welcome to Focus on Seniors, the television arm of Helping Seniors of Brevard County, a show designed to provide you with information on how to develop your own aging and care plans. Our topic today is glaucoma. With me on the studio set is Dr. Jim McManus of the Eye Institute, who specializes in cataracts and glaucoma. And we're going to talk a lot about that, and I'm sure that you're going to be made aware of some things that you don't know right now. So, welcome, Dr. McManus.
Thank you, Joe.
I'm glad to have you here. Just a couple of sentences about you, yourself, what you do in the community, and where you got your primary training. Just a quick overview.
I'm originally from the Northeast. I went to Dartmouth College and then to the University of Massachusetts Medical School, and then did my ophthalmology residency in Pittsburgh. Then I was in the Midwest for a couple of years, and then came to Florida in 1989. Well, my specialty is treating cataracts and glaucoma, and I've been doing that for about 22 years. I enjoy it for a lot of reasons because it's always rewarding to see a patient's reaction when you can help them see better.
That's an interesting way to phrase it, helping a patient see better.
That's what we do in cataract surgery. Glaucoma is, of course, a very different story, but in cataract surgery, it's something where a patient will see better quite quickly.
We got a name we call glaucoma, and I won't steal your thunder on that one. But what is glaucoma? Just what is it?
Glaucoma is a disease in which pressure inside the eye damages the nerve, and once the nerve is damaged, it's permanent. So our goal is to detect it early so that we can prevent that damage.
Is that why when you go to the doctor's office and you sit in that thing and you put your chin up here and it says you're going to feel a little pressure?
That's right. You used to use, air puff tonometry. That's not used quite as much anymore because of the fact that it's not quite as accurate as what we use nowadays. But usually people will use what's called a tonometer, and that's a little blue light that's attached to an instrument that can detect the pressure inside the eye.
Is that the one you move around, or is that the one that's...
It's the one that will be right in front of your eye.
Right in front of your eye.
Mm-hmm.
By making that light so bright, does that enable for you to see through and behind the eye?
People are always asking that. Actually, the lights that we're using are to see through your pupil into the back of the eye, because that's where we're going to be looking to determine if there's damage because of glaucoma.
There was an article that the Eye Institute did, and Dr. Mandisi and I know that you helped on the article, called, it was about glaucoma, the sneak thief of sight. Do we lay people have as good an appreciation for eye diseases such as cataracts, glaucoma, and other diseases as we should have?
Probably not, because in cataracts it's pretty obvious. A person will have trouble seeing. In glaucoma, the problem is that it's not easily detected by the person because there is no warning sign. There's no pain, there's no redness, there's no change in vision until very late in the disease. The only way to know if you have glaucoma or if you're likely to get it is to have a good exam with an eye doctor.
Well, Dr. Mandisi told me that I should ask you a question about really helping people understand that what they think might be a cataract problem is a glaucoma problem, or what's a glaucoma problem might in fact be a cataract problem. Maybe you can help our viewers understand the relationships and the differences between cataracts and glaucoma, because that's your specialty.
Sure. What a cataract is the lens of the eye that becomes cloudy. And what will happen is gradually over time, a person will notice that they're having more and more difficulty seeing. For example, they'll start noticing it's harder to read fine detail. They'll see that 6s and 8s get mixed up. They'll also notice that when they're driving, that they have to get closer to see street signs. They can still see the street sign, but they have to get closer to it. And the more difficulty that presents, the more difficulty they'll have driving. Glaucoma, on the other hand, is a disease which creeps up on the person. What'll happen is they'll start losing their peripheral vision, but it's so subtle in the early stages, a person's not aware of it. So that's why they're really different diseases. They're related in some respects in that if a person has cataract surgery, very frequently the pressure inside the eye will go down so that they won't need quite as much medicine to control their glaucoma. And that's usually a positive thing after surgery.
The way you described the cataract thing the first time brought back just a quick story. My wife and I had attended a reunion at the Naval Academy. I graduated from the Naval Academy, and we had gone to a reunion there. We were going to go back home in Falls Church, Virginia. Instead of going around the Beltway, we decided to go through Washington, D.C. It was about 2 o'clock in the morning. I have cataracts. I was driving, and I couldn't read the street signs. So I would drive up close to the sign, flash my bright lights, and I see what street it was. My wife would check it on a map. We go to the next one. After about 6 or 7 stops like that, I saw the red lights come on behind me. It was a district policeman. And I didn't get out of the car. He got out, came up, and he said, hey, I wondered why I was doing this. And I said, well, I just can't see that sign. And about the time he asked me to get out of the car, and I did. And the next thing he said, what submarines were you on? I said, what? I looked down, I had my big submarine belt buckle on. The guy had been in submarines. He said, don't worry about it. He said, are you trying to get to the other side of Washington? I said, yes, I am. He said, follow me. He did, and I was not kidding, he did like almost a wheelie in that street. I had a hard time keeping up with that policeman as he drove me. He took me all the way through Washington with his siren, with his lights going, got me over to the outside of Virginia. So it paid to have my submarine belt buckle on.
Oh, yeah, definitely.
But that was because of my cataracts. Mm-hmm. But that was years ago. And those cataracts have gotten worse now. And they're at a point now. And I've had them checked, and I talked to Dr. Palmer down at the Eye Institute. And I've got a condition on the cornea such that if I take the laser, use the laser, the pressure might wash the inside of the cornea off.
Well, that's true. What can happen is during cataract surgery, if you have something called Fuchs dystrophy, which means that the cells that keep the cornea thin and clear are not healthy, if you have cataract surgery, you're more at risk for the cornea swelling afterwards. So in patients like that, we'll counsel them before surgery to be on the lookout for that, because what it means is their postoperative course will be longer than usual. They'll still see better in most cases, but their postoperative course will just take more time.
I've also had other eye doctors over the course of time tell me, Dr. McManus, that even if the inside of the cornea should wash off, that they can replace the cornea now much easier than we did years ago.
That's true. Most corneal diseases are caused by problems on the inside part of the cornea. And in the old days, the only treatment for that was what we call a full-thickness corneal transplant, where you actually had to remove the front part of the eye, or the front part of the clear window of the eye, and in its place, you would use a donor cornea from someone who had passed away. Nowadays, the inside cells can be replaced separately in a much easier procedure so that the person recovers much faster.
Do you put a manufactured cornea in?
It's not manufactured. These are still donor corneas. So it's dependent on patients donating their corneas once they pass away.
I didn't realize it. So that if you have to have that, is that operation a common thing now or not?
It's not as common because a lot of the cases where the cornea would swell were due to cataract surgery initially. That was in the old days when cataract surgery was much more damaging to the eye. Nowadays, that doesn't happen quite as much. So the need for corneal surgery has decreased quite substantially.
Let's say, in my case, if I elected to have this type of surgery, what is the risk? What would be the risk factor if that lining washed off of my cornea? I don't mean to put you on the spot, but
that's okay.
Is there a pretty good chance that if it happened, I had to have a replacement that I would see just as well?
Generally, yes. What we usually do is wait until the person is noticing enough of a problem that that person is having difficulty doing their daily activities, that would justify having the cataract surgery. Then once the cataract surgery is performed, usually the person will see a lot better afterwards. If not, then we could consider performing the corneal transplant.
Yep. Because I noticed, and I'm sure since there are, I think it's 124,000 people in Brevard County, Florida, over the age of 65, that many of them are having the same problem I do. And I noticed that if I'm going to read something, especially at night or under a light, that I have to get very close to it to see.
That's right.
And my glasses, I've talked to the optometrist about it, and my glasses are, they can't really increase the strength of them anymore. So you reach a break point where you're facing surgery.
That's right. There's a point at which changing the glasses will no longer help. And when that happens, then we'll talk about cataract surgery.
Okay. Well, let's go back to your specialty. Let's go back to glaucoma. How common is glaucoma in the United States?
It's very common. There are probably about 2.5 million people with glaucoma. The sad part is about half of those people don't know they have it. That's what's really scary when you look at the statistics regarding glaucoma. The other scary statistic is by the year 2020, that number is going to rise to about 3.5 million people because of changing demographics.
What do you mean by change in demographics that would cause?
The population is aging in the United States.
All right, okay.
And also there are more Hispanics and African Americans. And in those populations, there's a greater likelihood of having glaucoma.
And Hispanics and?
African Americans.
African Americans are greater? Mm-hmm. Why is that?
It's believed that it's hereditary in many cases.
So sometimes it's difficult to escape our parents.
That's true.
I don't know, you can't see it on camera, but I got little lines in my hands on both sides, Dupuytren's contractions, and they were the gift of my mother.
Oh.
Are you aware that Dupuytren's contractions are passed from the mother to the children, not from the father?
From the father, right.
But I can work my hands now. A lot of people cannot do that. I've seen people with their hands like this because they can't straighten their fingers up. I had a very good hand surgeon that worked on me, and it was very good. But glaucoma, if it's recognized early enough, can it be successfully treated?
In most cases, glaucoma can be treated, and if it's treated early enough, a person won't even know that they have glaucoma in the sense that they won't have any significant problems with their vision. If you catch it early enough before a person has lost their peripheral vision, then they'll have just basically normal function.
Well, how does the glaucoma work? Does the peripheral vision go first?
That's exactly what it is. You lose your peripheral vision first, and it's only in later forms of the disease where a person will lose their central vision.
What do you at the Eye Institute, and I asked Dr. Mendizzi the same question. At the Eye Institute, the doctors there are more of have expertise in various areas of eye diseases. You're not a glass. You have glasses there, and you probably recommend glasses for people and
right, that's true.
And fit people for glasses, but mostly your main thrust is care of the eyes, eye diseases, cataracts, glaucoma, macular degeneration, things that make it very difficult people to continue having good eyesight as they get older.
That's right. That's what we try to do, specialize so that we can provide the best care.
How about describing some of the treatment options? I don't know all of them. I know the drops, I know laser, but like we talk about care, there are certainly lesser elements of care just in like you don't put somebody in a nursing home right away if you can put them in a daycare.
Right.
Same thing with eye care. And I think people need to understand that more, that the faster or the earlier you discover the onset of any kind of a disease, the better chance you as an eye doctor have in treating that.
That's exactly right. Most patients we can treat successfully either with medicine or with laser. The medicine is getting better and better. When I was a resident, medicines were 3 or 4 times a day. and that's really hard to remember. Nowadays, most medicines are once or twice a day, and they usually come in the form of eye drops, so a person doesn't have to worry so much about the systemic side effects, and that's really very important. The other treatment is laser. Now, laser is done in the office. There are no restrictions afterwards. A patient can have the laser done and go back to their normal activities just an hour later. It's also painless, and it's covered by insurance. So that's one of the things that patients are selecting to do more and more nowadays. The third option is surgery. And I do glaucoma surgery, but the good news is that with the introduction of laser and a gentler form of laser about 12 years ago, and modern medicines, the actual incidence of surgery is going down. It's about half of what it was 10 years ago.
So laser is a pretty good thing.
It's great. It really has transformed, I think, how we practice in treating glaucoma patients. Because once you present to the patient that they have the option to get off of their medicine, or you tell them that they can get away from the side effects from the medicine or the costs, that really has a substantial impact on them.
I'd be willing to bet that 90% of our viewing audience right now wouldn't understand what that laser does or how that laser works in taking the cataract or helping with the glaucoma. Can you help a layperson understand this in simple terms?
The easiest way to think about it is the laser stimulates cells inside the eye to clean out the drains so that more fluid passes through the drain and then the pressure goes down. That's the easiest way to think about it. It's kind of like a plumbing problem. If the drain isn't working, there's no place for the fluid to go, so the fluid builds up, and in the eye, since it's a closed space, pressure will build up. By helping the drain work better, then the pressure will go down.
So what does the laser burn the?
No, that's why the laser, as I was referring to earlier, it's a gentler laser. The old style of laser, up until about 12 years ago, was a heat laser. It actually burned the eye, and it worked by a different mechanism. What it did was it burned areas of the drain with the hope that the areas between the burns would be pulled apart so the drains would then work better physically. This laser works by a different mechanism. It stimulates cells that are actually in the body to begin with so that they actually do the work of cleaning out the drains, and then the pressure goes down that way.
Is that like a cold laser then?
It's a cold laser.
Cold laser. What is the relation of dry eyes to what you're talking about and glaucoma, or is there a relationship?
There really isn't a relationship between dry eyes and glaucoma because the pressure and the fluid we're talking about is inside the eye. However, patients who have dry eyes, they're going to be affected by the medicines that we use in treating glaucoma more because the medicines are going to sting more, they're going to have more side effects.
Wait a minute. Explain that again now.
Well, if you have dry eyes, your eyes tend to be sensitive. Okay. So when you have to put medicine in the form of eye drops, you're going to notice that the eyes sting more from the eye drops because all medicines have certain side effects.
Okay, I understand that. Okay. But is that good or bad?
It's uncomfortable for the patients. In some patients, if it becomes severe, it might actually lead to them not taking their medicine. And if they don't take their medicine, then they're not getting the coverage they need to protect their eye.
Okay. What are the adverse effects of laser surgery, though? Or are there adverse effects? There probably are.
There really aren't. What it can do is it can cause a transient rise in pressure, but usually that pressure will come down quickly after we give the patient medicine right afterwards in the form of eye drops. It sometimes will identify a patient that needs surgery, and that's what we've seen a couple times. You know, we do a lot of these lasers, obviously, and there are a couple times we've seen patients who then need to have glaucoma surgery, but they probably would need it anyway.
I'm going to try and say this word, and I probably will say it wrong, but I know that there's a thing for resurfacing the lining of the knee and the hip called megaplasty, which is a robotic type surgery, but you've got a thing called laser trabeculoplasty?
Perfect. You said it just right.
Is that correct?
That's right. Exactly.
What is that?
That's what I was talking about. That's what we are doing when we stimulate the cells in the trabecular meshwork. The trabecular meshwork is the drain. And if you stimulate those cells to clean out that drain, then the fluid will pass through more easily.
But you're finding, or I think, after I read the article in the paper about glaucoma, the silent thief, sneak thief of sight, the business with this, I'll call it the SLT for
SLT
short. For short, it's easier to say. A question I had, it said, what role do you think the SLT can have on the life of patients with glaucoma? Do you really see something new with all this technology coming along, see that this could really affect something positively?
We do, and it's both in helping the patient and it's actually helping the healthcare system as a whole, because we actually did a study in which, well, there have been studies done in the last couple of years, where they looked at the cost of lasers treatment versus the cost of medication. And what they found is that in most patients, if you treat the patient with laser, actually it costs less than if the patient has to take medicine. Although these medicines are very good, which I referred to earlier, they're very expensive. Even if a patient has good health insurance, their copay is still pretty high.
For the SLT treatment?
For the medicines.
For the medicines. So the SLT is cheaper than the medicines?
It's cheaper overall than taking the medicine.
Okay, well, since the focus of our show is seniors and senior eye care, were the medicines that were used covered by Medicare?
They were. And what was interesting, in a paper that was published within the last year, they actually looked at the cost of generic medicine versus laser. And the surprising result was it was actually cheaper to have the laser than to have generic medicine.
So how would that all wash out under affordable health care? This is not a political question.
No, it's not a political thing.
I'm trying to figure out, because, we don't understand what's going to happen with care. And I do know, I read a paper 10 years ago. It was published by CMS, Medicare, and Medicaid in Washington, D.C. And the thrust of the physicians that were participated in the study was that in order to drive down the cost of care, we have to figure a way to drive down the cost of the procedures. Mm-hmm. It's the only way we're going to do it. We can't just continue to say, we're going to pay the doctors less, or we're going to pay the hospitals less. That's not going to work. There has to be an element of practicality in what we're doing here. And I see that in some of the questions that I asked you to give me, mm-hmm. so we could discuss this topic intelligently on this show. And that's, if a viewer watches this show, I hope that they're going to get a better appreciation, Dr. McManus, about the significance of identifying glaucoma as early on as you possibly can. And what can you tell our viewers about how do you identify it? What do you do? Do you do regular eye exams, or do you do more frequent exams? You get to be 50, 65. What do you do?
Well, that's true. As you grow older, it's important to have an exam more frequently, because the incidence of glaucoma starts rising after you reach about the age 53. So after that point, you're going to start noticing that you're more likely to develop not just glaucoma, but other eye diseases that affect elderly patients. As far as detecting it, it's not something that you can detect just by looking in the eye necessarily.
Okay.
We can see certain characteristic findings when we look in the eye, but we also have to do tests. And that's why we're fortunate at the Eye Institute to have the appropriate equipment in order to do those tests efficiently for the patients. So we can get all those tests done in a very short period of time and have the answer for the patient, so that they know if they have no glaucoma, if they're a glaucoma suspect, or if they have glaucoma and they need treatment.
And I'm not sure if I do so many shows, I'm not sure if I asked you this question or not, but is glaucoma genetic?
It can be, but we only have about 1% to 2% of patients who have an identifiable gene for glaucoma. We can identify patterns in which we'll see it in a family, but we can't identify the genetic basis for that inheritance.
If is glaucoma very prevalent in anybody under the age of 65?
It's not as common as it is for seniors, but it is prevalent, because the median age is 53. So that means that half of the patients are going to be before the age of 53.
How do these people that are not covered by Medicare, how do they pay for these treatments and the medications if they're so expensive?
Well, if they have insurance, then a lot of health plans do cover medications, but there again, the patient is going to have to deal with the costs of their copays. The other problem is that if you're going to be dealing, let's say you're 55, and you're going to be looking at taking medicine for another 30 years, the side effects from that are going to be significant.
I wanted to ask you about that. Are the medicines that are used to treat glaucoma, do they cause a lot of side effects?
The side effects can be either local, which would be the more modern medications, or they can be systemic. The local side effects would be like redness, stinging, pigmentation of the eyes and the eyelids. The systemic side effects could affect the heart, breathing, make you feel depressed, weak, tired. So the systemic side effects of the older types of medicines that are used to treat glaucoma are substantial.
Okay. How about glaucoma itself? Once you identify it as a person is older, what are the dangers? And we're finding out more and more how different diseases interact with other diseases of the body. Does glaucoma in the senior tend to become more pronounced in showing up other diseases in the body? Or is there a connection?
There really isn't much of a connection in that regard. It's really located to the eye, per se.
So glaucoma is located to the eye, whereas Dr. Mendezi was talking about double vision, which is related to the optic nerve going to the brain.
Exactly.
So glaucoma is something we have to worry about. We actually could lose our sight if we fail to do something.
Exactly, and that's the problem. That's why it is so hard to detect it unless you have a good exam.
Okay. Thinking about everything we've talked about today, I can't think of anything that I would. What else would you might think that we have not covered?
Well, one of the things that we just finished was a study, and we were looking at whether or not patients could discontinue their medicines. Because when I counsel a patient regarding laser, I'll usually tell them if their pressure is not controlled, the purpose of doing the laser is to bring the pressure under control with their medicine. If the patient's pressure is controlled, but they are having side effects from the medicine, then the goal would be to get them off the medicine. We just finished a study in which we actually saw that if you look at patients who are treated just to get their pressure under control, 75% of those patients could actually decrease or eliminate their medicine. That was a totally unexpected result. We really did not think that patients would be able to stop their medicine. The goal of treating those particular patients was really to get the pressure under control with medicine. But as an added benefit, we were actually able to stop their medicine.
But that was a good result.
It was a great result.
Totally. I can see you smiling.
Yes, we were thrilled. We never expected that.
With that, we're out of time. And I want to thank you for watching today's episode of Focus on Seniors. If you have questions or comments, please call radio station WMEL AM 1300 at 321-631-1300. For more information on senior care and resources, visit our website, helpingseniorsofbrevard.com. And I want to thank you for watching, and I want to thank Dr. McManus for being here and giving the wonderful explanation he did. I hope you know more about glaucoma and its importance to you. Thank you.